Thank you very much for your introduction. Good afternoon. The topic that I've been asked to talk about is whether clomiphene citrate, anti-estrogen therapy, aromatase inhibitors, or recombinant HMG. Like we know, anovulation is responsible for about 20% of the female infertility, of which PCOS patients are the major category. In estrogenic anovulation, clomiphene citrate remains the primary therapy to induce ovulation. However, the mechanism of this drug works like clomiphene citrate blocks the estrogen receptors, creating a false impression of a deficient estrogen environment to the pituitary. Clomiphene citrate is an anti-estrogen that results in about 60 to 85% ovulation rate and just 10 to 20% pregnancy rate per cycle. The mechanism of action, like you can see in this cartoon, in which the clomiphene blocks the receptors in the level of the hypothalamic pituitary axis, and again it creates a situation in which the estrogen level is very low. That's why the pituitary responds by producing more FSH, and the FSH will work upon the ovary and produce the follicle stimulating action on the ovary. The disparity in the outcome of the anti-estrogenic effect of clomiphene citrate, which involves long-standing estrogen receptor depletion, as well known. Clomiphene citrate, like we know, accumulates in the body due to its long half-time, which is around 2 weeks, and thus may have an adverse effect on the quality and quantity of the cervical mucus, as well as on the endometrial development, causing implantation failure and luteal phase defects. Here you can see the effect of clomiphene upon the endometrium, and you can see that there's thinning of the endometrium instead of what we expect, like 8 to 10 or 12 millimeters. We may find a thinning endometrium in about 5 to 6 millimeters, which may affect the implantation rate. About 25% of the patients don't respond to clomiphene citrate in spite of the high doses. Because the anti-estrogenic effect is dose dependent, a daily dose of higher than 150 milligrams is not recommended, and it can be considered a high dose. In clomiphene citrate unresponsive cases, the next step for induction of ovulation is the use of either letrozole, aromatase inhibitor, or gonadotropins, which increase both the cost and the risk associated with treatment, mainly the gonadotropins. Prolonged estrogen receptor depletion results in significant thinning of the endometrium, like I said before. Thus, untoward effect of clomiphene on the endometrium may explain, in part, the relatively poor pregnancy rate associated with clomiphene despite the high rate of ovulation. On the other hand, like I said, about 25% will not respond in any way to clomiphene. Letrozole is an oral, potent, reversible, and highly selective aromatase inhibitor that prevents androgen to estrogen conversion. These aromatase inhibitors have a short half-time, which is about 45 hours, hence is rapidly eliminated from the body. No adverse effects of estrogen target tissues is seen with the letrozole due to this short half-time. Furthermore, it does not downregulate the estrogen receptors as we know with clomiphene citrate. Letrozole actually makes an estrogen deficient milieu by blocking the conversion of androgen to estrogens. Hence, the initial release of gonadotropins, namely FSH, may be more than in the case of clomiphene citrate. Letrozole, however, has an added positive effect because peripherally it may increase follicular sensitivity to FSH through amplification of the FSH receptor gene expression. This is the cartoon which describes the mechanism action of aromatase inhibitors. Like we said, it inhibits the convergence of androgens into estrogens, and by creating hypoestrogenic milieu, it will produce or push forward the pituitary to produce more FSH, which will affect the follicles in the ovary. And about day 10 of the cycle or treatment, you can see that the elevated estrogen will create negative feedback upon the pituitary and will decrease the amount of FSH which was produced early. Although aromatase inhibitors create an estrogen-deficient environment, it has no negative effect on the endometrium and cervix, like I said, because of its low, short half-time. On the other hand, in the clomiphene cycle, despite an adequate E level, there is an estrogen-deficient environment due to the blocking of estrogen and being long-standing. Therefore, ovulation induction by letrozole is superior to clomiphene citrate in terms of follicular growth and endometrial development. And in this issue, there is no doubt, which is these factors are very important, and even they are essential for competent and proper implantation of the embryo. Clomiphene citrate results in central estrogen receptor depletion for a lengthy time. However, as a result, supraphysiologic levels of estrogen can occur without central depression of FSH because the normal estrogen receptor mediated feedback mechanisms are blocked. This results in multiple follicle growth and higher multiple pregnancy rates with clomiphene citrate that then are found in letrozole cycles. So when the development of multiple mature follicles is needed, letrozole alone is probably not the optimal choice for ovulation of induction.